I'm going to go on to our next speaker. Our next speaker is a very popular public prosecutor, chairman and MD of BBI Foundation, Calcutta, and the ever charming scientific committee chairman of AIOS, who's going to talk on his favorite topic, Phakic IOL's essentials. We could keep a question in our minds for SMILE and the future topics as it goes on.
Thank you very much, Chitra, for this kind invitation to a very, very popular course that you are carrying on with the ARC team. Kudos to you and to your wonderful team. Wonderful talks we have had throughout the evening, and to chip in with Phakic IOLs, the essentials, and I'll try to keep it as basic as possible so that we can think about the essentials of the Phakic IOL and what it is there for refractive surgery. So refractive surgery is in two compartments, the laser refractive surgery and the non-laser refractive surgery, in which the Phakic IOL holds a huge promise and is taking up a large share of the refractive surgery as of today. So we have the ICLs and the other Phakic IOLs in the Indian market, and they are being well used in the market, and we need to know about them. So the ICL or the Toric ICL, these are foldable lenses, and they are posterior chamber sulcus located lenses, and it's a place that the location itself is a location which is stable and relatively atraumatic. Now, the ICL is made up of a particular copolymer, and it's a collamer lens with collagen and hemapolymer copolymer. And this has stood the test of time due to its excellent biocompatibility, excellent transmittance, and low reflectance patterns. And they are extremely flexible, foldable, and a very small incision is required to inject it. And the best part of it is also easily removable. Thereby, it becomes a surgery which can be reversed as well. So about the concept of the posterior chamber, and that's a very important concept for us, that is behind the iris. Now, why is it an important concept? Because this phakic IOL is going to stay in the eye of a, say, 20-year-old for the next 40 years, maybe, or more. So it has to be in a position that must stand the test of time. So this is far behind the endothelium. It is excellent in cosmesis and very close to the nodal points of the eye. The gain in the retinal size of the image is remarkable, and thereby a patient who is wearing, say, -10 or 12 or -14 diopters of glasses and is very dependent on contact lenses, he gets a wonderful feeling of not having to wear his glasses or his contact lenses, and thereby going about his or her normal activities. And the retinal size of the image is one very important factor that comes into focus. So the effective optical zone is also greater, and the sulcus in itself is a very stable location, and as we said, that it is easily removable and exchangeable. And the phakic IOLs, or the few of the first ones that came into the market, were the artisan lenses or the very sized lenses, and they were iris clip lenses. And thereby it was fixed to the iris tissue in the anterior chamber. But over the years, there were problems with these lenses, and there was corneal decompensation in some of these lenses, though a stringent anterior chamber depth was kept for these lenses to be implanted. The lenses at times, the claws or the fixation, they gave way, and the lenses at times fell into the anterior chamber, and thereby creating a lot of problem both for the corneal endothelium as well as for the visibility. Whereas this posterior chamber lens of the ICL or the IPCL and the other posterior chamber located lenses do not have this difficulty, and it does not either alter the shape or it does not remove tissue, and thereby the pristine cornea is intact. And again, if we look at some amount of time when this patient would develop cataract, the calculations of the biometry in a post LASIK or a post refractive surgery done eye is definitely a lot of challenge. Whereas in such cases, in the ICL or in the IPCL or in a Phakic IOL patient, the biometry, it is not a challenge, and the biometry is the same biometry principles that we adhere to in a phakic lens. Now, the design and the features and the availability, the myopia and the myopic astigmatism can be done. And I would like to speak upon the ICL, which comes in the range of -3 to -23 diopters. And this is both for the myopia and also for the toric lenses. And for the toric lenses, the cylinder power that can be corrected would be up to +6 diopters of cylinder power. The V4C, that is the developed, that is the ICL that has been well developed, and it has a central port, and this central port is a very important part in which the circulation of the aqueous is unhindered, and thereby it protects the lens, the crystalline lens, to an effect. And this has been a very, very important manufacturing strategy for these lenses. And these, the central port is 360 microns in diameter, and it is such that it does not create aberrations in the visual effect of the patient. And this V4C with the central port is available for myopic spheric and the myopic toric lens versions. Of course, in the hyperopic versions, the central port is not there. Why not there is a very important question which an examiner at times asks. And the answer is very simple, because the hyperopic lenses are thicker than the myopic lenses, and a 360 micron of aqua port or the central port would create aberrations in these lenses. Therefore, the corollary to this question is, so in which cases of the present day ICL is a PI mandatory, is a peripheral iridotomy or iridectomy mandatory? It is in these hyperopic lenses that it becomes mandatory. So the prerequisites of phakic IOL, the crystalline lens has to be absolutely clear. The patient should have refractive error which is stable for at least 6 months to 1 year, and definitely less than 0.5 diopters of change. We do not stick to this 18 years figure all the time, but what is important is the stability of the refractive error, and that is important because the same optometrist or the same physician or the same ophthalmologist should have checked the power of the refractive error of the eye before going on to phakic IOLs. Ametropia, and obviously that which is not suitable for excimer laser surgery. However, as we just discussed, the number of patients for phakic IOL is becoming larger and larger because of the stringent protocols that are being followed for the excimer laser surgery. Unsatisfactory patients are intolerant to contact lenses or spectacles. And again, when the initial corneal thickness is less than 480 microns. And LASIK in that particular eye will leave behind less than 300 microns of the residual bed. So this 300 microns is one figure that is again variable for different ophthalmologists, but by and large, the higher the dioptric correction to be done, the more the residual bed should be left behind. Therefore, that again becomes an important protocol in the excimer laser corrections. The other prerequisites are, of course, the anterior chamber length, depth, and that has to be greater than 3.2 millimeters if it is one of these iris claw lenses or the angle supported. Not much in use now. 2.8 millimeters for the posterior chamber IOLs. Again, another favorite question is, so what is the depth and from where is it measured? So it is the endothelium, corneal endothelium to the anterior, the capsular depth that is to be measured, not from the epithelium. The endothelial cell density is important, and we have a tabulation for the endothelial cell density, which is appropriate. Pathology of the eye, such as corneal disorders or glaucoma or uveitis of maculopathy, are contraindications. And the ocular examination is very important. Discontinuation of contact lenses at least 1 to 2 weeks, and especially if it is an RGP lens, definitely 2 weeks before the refractive error is ascertained. The refraction, the uncorrected and the best corrected visual acuity is important. Again, it is suffice to say that the best corrected visual acuity with spectacles usually increases, usually improves after a phakic IOL, and a binocular assessment is also important. The anterior segment evaluation, the pupil and the pupillary aperture is important. Again, a large pupil would mean, and the patient should be cautioned that there might be some amount of glare post-operatively, which usually comes down. The anterior chamber configuration and the iris topography and the iridocorneal angle estimation is also important, corneal and lens evaluation, and the measurements of the angle, the anterior chamber depth, the white to white, and the axial length, the intraocular pressure, and the gaze. The dilated slit lamp and ophthalmoscopy evaluation is important, and any peripheral lesions must be treated before doing and phakic IOL. So let's look at the more important parts of the investigations which we need to do, the white to white. And the white to white with the caliper is what must be done. And this caliper should again be well calibrated. It should be a digital caliper, and the eye should be treated with pre-anesthetic drops, and it should be measured under the microscope, the patient in supine position, and the caliper should be read either on the ruler or it should be read right on the scale that is given with the caliper. The anterior chamber depth is important and is defined a bit as the depth between the corneal endothelium and the anterior crystalline lens. It does not include the ACD measurement, and it's important to sorry for that. So what are the tools in which we look at the anterior chamber depth? And it's important because not all the tools give the right values. When we are looking at the white to white, the OBSCAN provides a very reliable value, and this should match between the two eyes, which is again very important. Unless there is some amount of pigmentation or some artifact on the sclera, and the mismatch is there but can be accounted for. So the IOL value of the IOL master, the white to white value by the IOL master, again shows two larger values, and they are not comparable to the OBSCAN or to the caliper. But this is something that we can remember, and both the values with the caliper as well as the IOL master may be taken to ascertain that that difference is very much there and is there in both eyes symmetrically. So if one takes the white to white value by the IOL master, it can lead to an oversizing of the lens. Now the ICL vault is the most important because it is going to be there in the posterior chamber and very close to the anterior, very close to the crystalline lens, and the vault should be just about 250 microns to 750 microns, and that is the range of the vault. And that measure, again, is a very important question. How do you measure the vault by slit lamp? Well, it is half of the corneal thickness to 1.5 times the corneal thickness is the correct answer. And again, a very favorite question for the examiner to ask. If it is an undersized ICL, it increases the risk of the anterior capsular opacification, which can lead to cataract and which can progress. An oversized ICL and is more than 1 millimeter or 1,000 microns may push the iris forward and the close to the angles which could lead to an intraocular power rise. So the ICL or the Toric ICL power calculation software is available and it calculates very well. The preparation for the ICL, the Toric ICL, is important. Again, the horizontal axis of this can be marked by the slit lamp, and this marking is important. Just an eye estimation might not be so accurate, and there are different devices. The bubble marker also can be used for the marking of the 180 degrees. Now let's look at the procedure, which is the most important part. The most important part of the procedure is loading of the ICL, and that's a step that has to be taken with a great amount of caution. So this is the ICL which is in BSS, and this ICL of the V4C does not increase in size after the placement inside the anterior chamber. And it's first placed on the cartridge and the hub, and this hub contains methyl cellulose and some half of BSS, and it is pulled into the nozzle. And once it is pulled, it's very important to see that I'm going to stop here just to show that it must be, the ports must be totally vertical, and it should be seen under the microscope before and the ICL enters into the anterior chamber. So the anterior chamber is filled with either methyl cellulose or with helon, and the insertion is very important. Side ports are made, and the manipulation of the lens inside is very important. And so we'll just look into this video, which shows that the methyl cellulose is filling in, but it is just about optimal fill that has to be done. And this optimal fill is important so that there is just enough of methyl cellulose and the ICL opens the correct way, because if it does not open the correct way, then it's an upside down ICL which comes in with a lot of difficulty, and this has to be removed, and again it has to be placed the right side on. So the 3.2 millimeters incision is made, and it's important for beginners to put the nozzle inside the anterior chamber and to see the unfolding of the ICL, and it should fold the right side up, and the leading haptic should bear that hole, and it's important to see the leading haptic going in onto the pupil. The ICL should not plunge in the sulcus immediately, and the foot plates are gradually placed in the sulcus by the manipulator very atraumatically. And once that is done, then the removal of the viscoelastic is important. Here, either if it is helon, it comes out in bulk, or if it is methyl cellulose, it has to be removed very gently. And the amount of viscoelastic left behind, there at times is a little bit of viscoelastic left behind, but should be as minimal as possible. So these are the post-operative pictures, and usually the patient needs the best corrected visual acuity, and it is usually there is hardly any complaint of glare and halo, but a few patients might complain. And a 2-hour post-operative examination to check the intraocular pressure. If there is intraocular IOP elevation, it most likely is because of the retained viscoelastic. We do not do iridotomies in most of these cases, as we just discussed. And if it is, of course, done, then the PIs should be checked. The ICL vault is also something that needs to be checked. a quick word about the complications. The preoperative power, sizing, everything must be checked and cross-checked and double-checked and checked 3 times before an ICL is implanted, because there have been instances where a wrong ICL has gone in, which has to be removed and replaced again. The wound construction is important because, again, these are young patients, they might squeeze, and a shallowing of the anterior chamber is something that is not required. Loading of the ICL, as we just mentioned, is very important. Insertion of the ICL has to be atraumatic, and if there is trauma on the anterior capsule, that can lead to an anterior subcapsular cataract. The early postoperative elevated intraocular pressure must be determined and can cause a drop in the vision. Traumatic cataract, of course, is something of a rarity. Late postoperative glare and halo and iris transim illumination defects might occur. Cataract and glaucoma are possibilities. Glaucoma, again, because these are high myopes and can come up with glaucoma at any point of time, so they have to be kept under check at least after every 6 months to a year. Long-term findings, pupil ovalization, very, very rare, and pigment on the lens or oversized ICL, again, is quite a rarity. A few words about the IPCL. Now, this is a
running short of time, Partha.
Yes, I'll just wind up in 1 minute. Hybrid hydrophilic acrylic material, and it comes customized, and the range is huge, -1 to -30 diopters or +1 to +15 diopters. And the IPCL has design, and it can be implanted right transversely 0-180 degrees, even though it might have a toric variety, and it has a huge economic advantage, and customization of the IPCL can take place. The disadvantages need for a PI, and there have been comparative analysis and which show that both the ICL and the IPCL are very, very good and effective. Thank you very much, and thanks once again to Team ARC for the opportunity.
That was a superb talk, Partha, very informative. But I think, why would you need to do a PI for an IPCL?
PI for an IPCL?
Current model doesn't.
New model, we don't.
Models have all the openings.
It has a central hole.
Only one thing I would like to clarify, that for the age, I think Partha, of course, we are doing, I mean, people are doing for less than 18 years, but as per the FDA, the age for ICL that is approved is more than 21 years. And for the other procedures, it is less than 18 years. For LASIK, it is less than 18 years.
Thanks, Namrata. Anaga, can you introduce the next speaker? I wish we could have had more discussion, so much to ask, but I think we're really running late.